Our next speaker is going to be Ms. Jane Thomason. Ms. Thomason is an industrial hygienist for National Nurses United and a tireless advocate for healthcare workers. Ms. Thomason has observed firsthand the acute and long-term ravages that COVID-19 has had on the nursing workforce. She is the driving force behind the national initiatives to strengthen the CDC's patient and worker safety recommendations for preventing the spread of airborne pathogens. She is also a co-author on a recent peer-reviewed article entitled Public Health Experts Ask CDC Director to Broaden Input on Revisions to Key Infection Control Guidelines. Ms. Thomason will present on the impact of long COVID on nurses. Ms. Thomason, the floor is yours.
Thank you so much, Dr. Kavanaugh. Like Dr. Kavanaugh said, my name is Jane Thomason. I'm a certified industrial hygienist for National Nurses United, which is the largest labor union and professional association for registered nurses in the United States. NNU represents nearly 225,000 members nationwide and has led work to document the impact of the COVID pandemic on our members and all healthcare workers. NNU continues to lead the way in winning protections for healthcare workers and patients, including through collective bargaining, winning local and state policies, and fighting for federal standards and guidance. And today, I will be specifically focusing on the impact of long COVID on nurses and our work around this issue. So first, I think it's essential to recognize the fact that healthcare employers have utterly failed to protect nurses from COVID throughout the pandemic. Since 2020, NNU has conducted 8 nationwide surveys of registered nurses regarding their experiences of the COVID pandemic. We're currently gathering data on a 9th survey. Collectively, we have gathered data from over 85,000 nurses who work in all 50 states, DC, and the US territories. Each of these surveys has asked nurses about protections in their workplaces, including personal protective equipment or PPE, patient screening and isolation, testing, and staffing. And as you can see in some of the results highlighted here on the slide, employers failed to prepare for and protect nurses during the pandemic. For example, in March 2020, only 30% of nurses reported that their employer had sufficient PPE stock on hand to protect staff during a surge in patients with the novel coronavirus. In March of 2021, 81% of nurses were still being forced to reuse single-use PPE, a dangerous and unproven practice that many healthcare employers embraced after the CDC downgraded its COVID infection control guidance in the middle of 2020. At this point, only 52% of nurses reported that all patients were being screened for COVID. In April of 2022, only 72% of nurses reported wearing a respirator for every COVID-positive patient encounter, even though the precautionary principle demanded airborne precautions at the beginning of the pandemic. And by this point, the scientific evidence was abundantly clear that SARS-CoV-2 is airborne or aerosol transmitted. Also, at this point, only 24% of nurses were being notified of COVID exposures by their employer in a timely manner, a measure that has been shown to be important for stopping transmission in healthcare settings. So, as a result of their employer's failure to protect them, nurses and other healthcare workers have experienced a high rate of exposure to SARS-CoV-2, which has then led to high rates of infection, severe disease, and death. For example, one study found that healthcare workers were 11.6 times more likely to test positive for COVID than the general population. Healthcare workers were 7.4 times more likely to have severe COVID than non-essential workers. There has been very limited tracking of occupational exposures, infections, and deaths in the United States. So NNU conducted our own data gathering, and based on publicly available sources, counted 5,752 healthcare workers, including 499 registered nurses who have died from COVID as of May 19th, 2023. And it's as of that date because that's when the public health emergency ended and a lot of the public data sources that we were using disappeared. This is almost certainly an undercount of the true toll, but it is a much more thorough tracking than what the US government and the CDC provided. For example, as of May 3rd, 2023, the CDC had reported just 792 healthcare worker deaths from COVID. It's also important to recognize the disparities in which healthcare workers have been most impacted. NNU's data shows that 54% of the nurses who have died from COVID are nurses of color, even though they comprise just 24% of the nurse workforce in the US. So it comes as no surprise that nurses and other healthcare workers have experienced high rates of long COVID. Like many other speakers have noted, there is no systematic tracking of long COVID cases in the United States. Data from the UK, which utilizes a more systematic method to gather data on long COVID, recently found that health sector and social care sector workers experienced higher rates of long COVID than any other sector. Other studies have also documented higher rates of long COVID among nurses compared to other occupations. NNU has also collected data from nurses regarding their experiences of long COVID. Our December 2022 survey, which had nearly 3,000 nurse respondents working in 47 US jurisdictions, found that after recovery from an initial COVID infection, a large proportion of nurses reported ongoing long COVID symptoms. 80% reported experiencing tiredness or fatigue, 52% memory or concentration difficulties, 51% joint or muscle pain, 48% headaches or migraines, difficulty breathing or shortness of breath, symptoms that get worse after physical or mental activities, heart palpitations, chest pain. And for many of these nurses, symptoms lasted for a long time. You can see 31% reported that their symptoms lasted for between 0 to 3 months, 16% lasted 4 to 6 months, and then almost 20%, 17.9%, reported that their symptoms lasted more than 12 months. This survey also asked nurses about treatment for long COVID. A majority of nurses reported that they had not sought any treatment for their long COVID symptoms. Of those who had sought treatment, only half actually received it. For those who sought treatment but did not receive it, the most common barrier reported was that nurses were not being believed about their symptoms. We also found that for a significant proportion of nurses, their long COVID symptoms affected their ability to work. And I think it's really important to recognize not just the numbers and the quantitative impact, but the human impact of the long COVID crisis. We've heard this from other speakers today. And for nurses, these are just a handful of accounts that have been shared with NNU and our surveys about long COVID. And among just these 10 nurses' experiences, you can see a diversity in the impacts of long COVID, some of which are very severe, especially when you think about the types of work that nurses do. One nurse said executive function decreased, sleep affected majorly. Another reported, I have been labeled a COVID long hauler and require sinus surgery due to the effects of COVID, but cannot receive workers' comp and don't have enough sick time to cover it. Having a hard time organizing and charting at times in a timely manner. I spent 7 months out sick. My employer didn't even send me a get well card. Now I can't afford health insurance. COVID has brought on so many unexpected physical problems that are now life-changing. The chronic fatigue is profound. I had bilateral pulmonary embolisms and now severe restrictive lung disease. My employer is fighting workers' comp despite having many specialists say this is due to COVID. I require 3 to 4 times my pre-COVID caffeine intake to function post-COVID. I had fatigue for 3 months after having COVID and still have shortness of breath and tinnitus. It is just worrisome, the long-term physical effects. I feel like there's no protection for nurses, especially the ones who took care of COVID patients in the future if we become debilitated because of this. You can see the really serious impacts on nurses' physical, mental, emotional, social, financial health in just these few comments. And that brings me to another really important piece of understanding the impact of long COVID on nurses, and that is recognizing the significant role that long COVID is playing in the staffing crisis in healthcare. NNU's survey found that many nurses had to take time off from work to recover from their long COVID symptoms, and for many, it was an extended period. Some nurses shared in our surveys that they had to leave the bedside or even move to another area in healthcare because of the impacts of long COVID. I think everyone recognizes at this point that there is a staffing crisis in healthcare. Turnover and vacancy rates have skyrocketed. In the past 5 years, the average hospital has turned over more than 95% of its RN workforce. Healthcare employers have claimed that a nursing shortage, a shortage of nurses, is preventing them from hiring. But the reality is that there's no nursing shortage. There are over 1 million currently licensed RNs who are not working as nurses in the United States. This is based on NNU's analysis of publicly available data from the Bureau of Labor Statistics and the National Council of State Boards of Nursing. There is a shortage of good jobs where nurses are respected, staffed safely, and protected from hazards like COVID-19. Long COVID and the moral distress and abandonment caused by the failure of employers to protect nurses and their patients throughout the pandemic are major reasons contributing to nurses' decisions to leave the bedside or the profession entirely. For example, a survey of nurses who had left their positions between December 22nd, 2021 and January 17th, 2022 in Minnesota, which was conducted by the Minnesota Nurses Association and NNU state affiliate, found that unsafe and unsustainable conditions related to the COVID pandemic were a significant factor for many nurses in their decision to leave. When employers fail to safely staff units, it puts patients at risk as well. Research has connected higher turnover rates to increased medical errors, patient mortality rates, and longer lengths of stay. Nurses have also reported to NNU that they are seeing an increasing number of younger patients coming in with diseases that we typically think of as related to old age. Heart issues, lung issues, new onset diabetes. We've heard other speakers talk about these issues. Nurses are sharing that no one is making the connections between past COVID infections and these new conditions for these patients, except of course for nurses who have educated themselves on the issues of long COVID. I think it's also essential to recognize that the threat of long COVID is not gone. Healthcare employers continue to fail to protect nurses and other healthcare workers from COVID. NNU's 9th survey is still collecting data, but preliminary report with nearly 2,500 respondents from 50 states, DC, and Puerto Rico is available. And I can share these preliminary results with you. We found that only 31.5% of hospital RNs report wearing a respirator for every COVID positive patient encounter. And I just have to say that this is an extremely disturbing number, as it is abundantly clear that COVID is aerosol transmitted. It's clear that a respirator is needed. It's essential protection for COVID. Of course, in addition to other measures like ventilation, patient screening and isolation, universal masking, paid sick leave, exposure notification, all of these measures need to be in place. But the respirator is a truly essential protection for the nurses who are up close and personal, providing that hands-on care for patients. Nurses continue to be exposed to COVID in the workplace. In just the past 2 months, CDC's data indicates that over 150,000 patients have been hospitalized with COVID in the US. Add to that reinfections significantly increase the risk of developing long COVID. And I would point out here that NNU's December 2022 survey found that 70% of nurses report having been diagnosed with COVID, with 28% having had more than one infection already. It's also important to recognize that, as other speakers have noted, vaccines can reduce long COVID risk, but they do not fully prevent long COVID. And so the continued lack of protections in the workplace means that nurses remain exposed and at risk of another reinfection and long COVID. I think it's also important to call out that the CDC has failed to center the risks of long COVID in any meaningful way. There's very little public awareness of the long-term health risks tied to COVID infections. There's very little public awareness that repeat infections can dramatically increase the risk of long COVID. We can see the CDC's choice to deprioritize the risks of long COVID very clearly in their current efforts to weaken infection control guidance in healthcare settings. And many of you might recognize this table was also in Dr. Kavanaugh's opening remarks. So right now, the CDC's HICPAC, their Healthcare Infection Control Practices Advisory Committee, has initiated a process to update the 2007 isolation precautions guidance for healthcare settings. That's the foundational guidance that's used around the world and incorporated by reference by multiple enforcement agencies. It is, of course, time to update this guidance. It's been almost 20 years. There's been a lot of scientific developments, but what the HICPAC and their work group are developing are problematic. So in June of 2023, HICPAC's work group that is developing the updates to this isolation precautions guidance presented their proposals at a public meeting. And their proposals are extremely concerning on a number of points. I don't have time to go through all of them today, but briefly, HICPAC is proposing a new category of transmission to replace the disproven airborne droplet dichotomy. They are calling it transmission by air or through the air. And within this by air transmission category, HICPAC is proposing 3 new categories of precautions, which you can see on the slide. This is the table excerpted from the June 2023 workgroup presentation. Routine air precautions they are proposing for pathogens like seasonal coronaviruses or influenza, those get a medical surgical face mask for the healthcare workers providing care to those patients with those types of pathogens. Novel air precautions for pathogens like MERS, SARS-CoV-1, and pandemic phase respiratory viruses like influenza and SARS-CoV-2 are proposed to get an N95. This proposal denies the scientific evidence on aerosol transmission and inappropriately treats masks as protection against inhalation of hazardous aerosols. It sets the stage to lower protections for COVID from an N95 to a surgical medical mask whenever the CDC decides to deem COVID as in a seasonal phase and no longer a pandemic phase. And this is the clear plan of the workgroup and HICPAC based on discussions at past meetings. But a pathogen doesn't change the way it transmits just because we call it by a different name. I think it's also important to recognize that this table was developed based on a biased evidence review conducted by CDC staff for the workgroup. This review concluded that N95s were no different from surgical masks in terms of protection offered to healthcare workers against respiratory viruses. The evidence review looked extensively at adverse effects of N95 use, skin irritation, acne, headaches, but failed to account for the adverse effects of infections like long COVID, which can cause serious debilitating health effects. And so the CDC's refusal to acknowledge the risks of long COVID is directly at play in how the agency continues to put healthcare workers and patients at risk through weak and unprotective guidance. I would also note that in HICPAC's proposals that the extended air precautions category tracks onto the existing airborne precautions. So really these proposals from this committee don't update existing guidance based on any of the science that's developed in the last almost 20 years. And it actually moves backwards in a couple of important ways. I can drop a link in the chat to NNU's webpage on these issues if you're interested in more information or more details. You can see the link to the workgroup on the slide, and perhaps we can include that in the follow-up to attendees. We can include the link. But if you go to nationalnursesunited.org, on our homepage, there is a link to more information about what's happening at HICPAC if you're interested in learning more or if you would like to take action to urge the CDC to not weaken guidance. I think something that's been very clearly made, a point that's been very clearly made by many of the panelists so far today is that we cannot afford more long COVID. But what HICPAC and the CDC are proposing here with these guidance updates would increase everyone's risk of healthcare-acquired infections, COVID, but also a wide range of other pathogens that are present in healthcare settings. And this brings me to actually my final point, and that's the need for enforceable protections. So it's clear from the data that I've presented and nurses' experiences on the front lines throughout the ongoing COVID pandemic that healthcare employers are not doing what they need to do in order to protect patients and healthcare workers from infectious diseases voluntarily. Enforceable mandates are necessary. Nurses with NNU have been calling for an enforceable standard under the Occupational Safety and Health Administration, or OSHA, since March of 2020. As a result of nurses' diligent advocacy and action, we did win an emergency temporary standard on COVID in healthcare in June of 2021. This was an enforceable standard. It was in place for 6 months, and it did result in improvements in nurses' workplaces across the country that did prevent COVID infections. But this ETS was only intended to be a temporary stopgap measure until OSHA finalized a permanent standard. And that permanent standard has been stuck in the last part of the review process for many months now. Nurses continue to advocate for these protections. Nurses continue to need these protections. The only way to prevent long COVID is to prevent COVID infections in the first place, and especially to prevent reinfections. Workplace protections are essential to prevent future long COVID cases amongst nurses, other healthcare workers, and their patients, and amongst other frontline workers. It's also important to say that nurses have been and continue to advocate for a broader infectious diseases standard that would protect all workers from aerosol transmissible diseases in their workplace, including COVID. Nurses saw too many frontline workers become their patients during the pandemic. I think the COVID pandemic has just so clearly demonstrated that our health is interconnected and that worker protection is a really essential part of responding to the pandemic and protecting the health of all of us. So those are the remarks that I had prepared.
Jane, thank you for a very, very interesting and informative talk. You certainly have more energy than I do. I'm much slower with my presentation style. But I think emphasizing the risks that healthcare personnel are under and nurses are under is extremely important. More and more research is being published on viral dosage, exposure time, and certainly when you talk about professions, when you're actually being asked to treat a COVID-19 patient or in a facility that has COVID-19 patients, but aren't putting them in negative airflow rooms, you're going to be at a much higher dosage of viral exposure. And this is going to lead to not only more infections, but more severe infections. And this is why it's so important that if you have a patient with an infectious disease, put them in a negative pressure room and make sure that staff have N95 masks or elastomeric respirators. Elastomeric respirators are very effective, can be reused, and over the long term have less cost than N95 disposable masks. But yet, for some reason, there's this focus on a surgical mask that's going to protect you or give you adequate protection from these types of pathogens. And certainly with COVID-19, with the high infectivity rate and the very low amount of viruses that is going to be required to get an infection, a surgical mask is not going to give you adequate protection. The other important factor that I've seen that I think is very important in this is the lack of data. They're not tracking healthcare workers' acquisitions or deaths, nor are they tracking patients' acquisitions of COVID-19. For patients, the metric is absolutely nonsensical. You have to be in a hospital for 14 days and then develop COVID-19 while you're in the hospital. Most patients are discharged a little after 4 days. And so there's very little chance that that metric is going to pick up a hospital acquisition of COVID-19. In fact, the first year, in 2020, the guidance was that if the patient recovered, you don't have to even report. And so this is all extremely disturbing. We don't have the data, but yet you know from just looking at your colleagues that they're becoming severely affected. Health Watch has had a number of our healthcare providers on our board that have developed long COVID. We had one very close and good supporter that died after treating patients with COVID-19. And that person was fully vaccinated. It was during the Delta period. He had his vaccine very much early on, and it was in August before the boosters were available or even considered to be necessary. He was greater than 6 months out. He was in his 70s, and he succumbed to the disease. So we're seeing a lack of data, a lack of action, and healthcare workers consistently being placed in situations where they're exposed to a high viral load and viruses. And so to me, this is very disturbing. It has to stop, because if it doesn't, we're not going to have a healthy workforce. And I think that we're already starting to see this happening. Again, many of our leaders are still under the assumption that COVID-19 isn't anything worse than the flu, and we don't need to worry about it.